Hello, and thank you for the opportunity to be here. My name is Morgan Bowling, and I am an attending physician in pediatric emergency medicine at the Mount Sinai Hospital in New York City. Today, I want to take a few minutes to talk about trainee wellness in U.S. medical education, not just as a domestic issue, but as a potential roadmap for global standards. Over the next few minutes, I'll walk through three specific topics. First, what the data has to tell us about burnout. Second, how the United States built a regulatory and pragmatic response. And third, what lessons we can translate into global practice. The starting point, as always, is the data, and it's sobering. About half of US medical students report burnout. Among residents and fellows, that number has hovered around 50% in recent years. At the peak of COVID, physician burnout reached nearly 63%. Now, there is some good news. By 2025, resident burnout rates had dropped to about 28%. That improvement is important, and it's not accidental. It reflects intentional system level interventions, not individual resilience training, not telling residents to just take care of themselves, but true structural change. And that distinction is really the core of this conversation. Burnout is often phrased as just a personal issue, and it's not. It's also a patient safety one. We know that burnout is associated with increased medical errors, decreased empathy, and lower quality of care. So when trainees are struggling, patients are directly affected. For the trainees themselves, the consequences are serious. Depression, anxiety, substance abuse, and tragically, higher rates of suicide compared to the general population. And at a systems level, burnout leads to early career attrition, which worsens workforce shortages in places that can least afford it. What's critical here is that the causes are largely upstream and structural. Excessive work hours, a culture that discourages help seeking, high stakes exams, financial pressure, and lack of support systems. And because they are structural, they are also fixable. The US response has been very deliberate and, importantly, regulatory. At the residency level, the Accreditation Council for Graduate Medical Education, or more commonly known as the ACGME, sets national accreditation standards. These include the 80-hour work week, mandatory time off, and since 2017, explicit requirements around trainee well-being. Programs are required to provide education on burnout and mental health, ensure confidential access to care, and actively monitor wellness. If they don't comply, they risk losing accreditation. At the medical school level, the Liaison Committee on Medical Education, or more commonly known as the LCME, plays a similar role. Schools must demonstrate they support student well-being, provide confidential mental health services, and maintain policies that reduce unnecessary stress. One of the most impactful changes was making the USMLE, or the United States Medical Licensing Exam, Step 1, pass fail. That single decision removed a major source of anxiety for students nationwide. The key takeaway here is simple. Wellness cannot be optional. It must be built into the accreditation system. At the program level, US medical schools have moved toward structured, multi-layered approaches. Many now have longitudinal wellness curricula that run throughout all 4 years. These are intentionally non-graded so they don't add pressure, but they normalize conversations about mental health and professional identity. Peer support programs are another high impact intervention. Students are trained to support each other, particularly during high stress periods. These programs are low cost and benefit both the person receiving the support and the peer providing it. There has also been a strong push toward improving access and reducing stigma. This includes confidential counseling, anonymous screening tools, and even opt out mental health visits. where students are automatically scheduled unless they decline. And importantly, institutions have created dedicated offices of well-being to coordinate these efforts and ensure accountability. For residents, the evolution has been both structural and cultural. Before 2003, residents often worked over 100 hours per week. The 80-hour cap was a major shift, and it established that trainee well-being matters. More recent changes have focused on explicitly addressing burnout and meaning in work. Programs like Back to Bedside fund resident-led projects that reconnect physicians with the purpose of patient care. One particularly effective intervention is opt-out therapy, where residents are scheduled for mental health visits by default. This significantly increases utilization because it removes barriers of having to seek help. The common theme across these interventions is that they reduce friction and redesign systems rather than relying on individuals to just cope better. So, what lessons can we take globally? There are three key pillars. First, regulatory mandates. Wellness has to be embedded in accreditation standards. Without accountability, change is inconsistent. Second, structural reform. Burnout cannot be solved by teaching resilience alone. Work hours, evaluation systems, and administrative burden all need to be addressed. And third, culture and access. Even with the right policies, trainees need to feel safe seeking help. That requires visible leadership, peer support, and confidential, proactive mental health services. The United States has made some progress, but burnout is still far too common, which tells us that this is not a local issue. It's inherent to medical training worldwide. I'll close with 5 concrete actions. First, advocate for accreditation standards that include wellness requirements. Second, implement work hour protections and frame them as patient safety measures. Third, launch low-cost, high-impact programs like peer support and opt-out mental health services. Fourth, measure outcomes. Track burnout and attrition so that policy is driven by the data. And finally, build international partnerships just like this one to develop shared standards and accountability. Because ultimately, the health of our trainees and the quality of patient care are inseparable. Thank you so much for having me, and here is my email. Please reach out for more.